I am really happy to be here to hear from all these amazing speakers and so much feedback from the audience and the patient testimonials. I'm going to try to sort of briefly overview a few topics within the framework of C. diff from a pediatric gastroenterologist's point of view. We'll touch on the epidemiology of a C. difficile infection in children, look at how clinical heterogeneity, risk factors, and treatments for children are a little bit different than what we think about for adult care, and just highlight how this is a very vulnerable population with limited treatment options and really needs all of the efforts that are being put forward to help treat C. difficile infection in adults to really be magnified in children who are sort of still waiting for big breakthroughs. So this is a really nice schematic that came from the American Academy of Pediatrics a couple years ago and highlights all those big numbers that we've talked about with pediatric C. difficile infection. About 20,000 children per year are affected. And I think it's really important to remember that when you take care of a child, you're not just worried about the child, but you have to think about the whole family. And so this is really impacting many, many more people beyond those 20,000 children who are so severely affected. And about 3 out of 10 of those children will have a recurrence within the 2 months after their initial infection. And we do see that most children are picking this up in the community. And so I think that is a big shift from the previous thinking about where C. difficile infections are coming from. So we have data from a couple different places that really show this shift from healthcare acquired C. difficile infection to community acquired. In the FIS database, which really looks at inpatient hospital stays, we have seen even in most recent data that the cases of C. difficile infection have gone down from 2013 to 2019 of the number of cases of C. difficile infection in over 10,000 patient days. And I think this is just sort of reassuring that we're seeing less of this in the inpatient setting. But I think also that importantly that they noted there was less C. difficile infection testing being done overall. And I think that really moves to the differences that are happening with diagnostic stewardship in the hospitals and the efforts that people are putting forward to really test where the infection truly can be found or should be found. In the outpatient world, they've also looked at the CDC Emerging Infections Program, which is an important program that can survey these different kinds of infections and the shift from healthcare-associated infections to community-associated infections amongst adults and children, has seen that community-associated has surpassed healthcare-associated in all age groups, including children, where we see about 21 per 100,000 persons currently per year. So I think what's really different about C. difficile and how you think about it in pediatrics versus adults is the spectrum of disease and how it's a different shift. It's sort of shifted in a different direction than adults. And I think the biggest difference comes upon the amount of colonization that we see in our patients. So it's been reported that about 41% of infants can have to be asymptomatically colonized with C. difficile, and many of these infants actually have a toxigenic strain. So we know it's not just that there's different types of C. difficile that's colonized there, but there's something different about the infants. And this number goes down as children get older, but it's still pretty significant amongst toddlers and even in school-age children, until we see that asymptomatic colonization is pretty unlikely in healthier adults. We also have to learn more to understand the spectrum of infection that you can see in children. So it's, I think, pretty well established that there are the symptoms of mild to moderate C. difficile infection, diarrhea, abdominal pain, blood in your stool. Maybe it's you're taking care of at home versus in the hospital, or some early signs of dehydration that land you in the hospital. Severe and fulminant C. difficile infections, though, are really based on adult criteria to make that diagnosis. And this is tricky because many children would not qualify for episodes of severe disease, but they've landed in a pediatric ICU. And so I think because the ranges for an elevated white blood cell count, the ranges for different lab values that help qualify what type of event this is are different in young children than they are in adults. These definitions are a little bit murkier and make it difficult for us to track and identify these cases on sort of a bigger systematic level. In general, though, children do also have a much less likely mortality from C. difficile infection, which again, I think poses questions about what's different in children than adults that leads to this. And some of the questions why are things that we have been kind of returning to over and over again in the research that we've done here at CHOP to try to understand what is different about the child that allows for the clinical differences to happen and sort of the outcomes to be different. And things that have come into play, of course, are the dynamic intestinal microbiome and the metabolites that it makes. children's microbiome are not set until they're past 3 to 4 years of life. And so that early evolution of what is inhabiting their gut, I think, is a really important question that remains not totally answered. And at the same time, their immune system is evolving very quickly and is being educated, it's being vaccinated, it's being infected. And I think all those things also can impact how it responds to different microbes. There's also thoughts about difference in expression of proteins or receptors that can detect or respond to C. difficile. And there's also different lengths of time of exposures and different types of environmental exposures in children than adults that may lead to infection or colonization. Many of the risk factors that we think of for C. difficile infection in children are similar to adults. I have age highlighted here because, of course, older age is not anything that any pediatric patient has to worry too much about. But age is sort of a protective factor, as I said, when you're very young, where it's unlikely to have a C. difficile infection. I think another key point in children to think about is that there are studies that have shown that a good portion of patients have no risk factors for community-acquired C. difficile infection, have not had antibiotics recently or any other medication, don't have other underlying comorbidities. And so this is also a question we have about what puts those children at risk. So we have established a C. difficile pediatric biorepository at CHOP where we collect all of the incoming positive stool samples from all patients that come to our healthcare system. And as well as we have associated clinical metadata to go along with it to really understand the breadth of our population and what factors age and other clinical factors have in this. We have created a parallel biorepository at HUP, which is next door with the adult hospital. And we're hoping to use this to help us really understand the breadth of the C. difficile genomes that we have in our community, to identify new targets for vaccine development that's ongoing at CHOP and Penn at this time, to look at the rest of the microbes that are part of these stools that sort of might contribute to why C. difficile infection may have different clinical outcomes. And we just start continuing to try to further collaboration and research across the lifespan, because I think there are lessons to learn in pediatrics that could inform adults and vice versa. We've collected over 1,000 samples. A third of them are pediatric. We were surprised to learn how young our patients are. And I think this really comes into play when we think that many of the therapies that are available are not accessible or made accessible for young children to take. They have to come in, solution instead of pills or other ways to be able to administer. So I think these are important features that, will help us inform how we move forward with different new therapies or trials. We did find that many of our patients that had recurrent CDI, about a third of our pediatric group, have a recent or current enteral tube, and a third of them have malignancy and other major comorbidities as well. So, in pediatrics, we have our own algorithm for trying to set up patients for testing and identifying infection. NASPGHAN is the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and is sort of our PGI go-to for guidelines and a consensus. And I think they do a really good job of identifying that having a clinical suspicion of CDI really includes keeping age in mind, and is an infant with diarrhea worth testing? And I think this is really established which patients should be tested. And I think that has helped create different stewardship guidelines for testing in pediatric hospitals. We also recommend a multi-step testing approach to try to increase the sensitivity and specificity as much as we possibly can, although those are all excellent tests that are available to test for C. difficile. And then we try to decide are they mild, moderate, or severe. But like I said, this is tricky since there aren't specific definitions for these severity. And from there, we have a few limited options available in our armamentarium to treat C. difficile for children. It starts with metronidazole, it's followed by vancomycin, and that's kind of where the guidelines have ended so far. And we hope for clinical cure, but we know that our children are at risk for 25% risk of a first recurrence, and once you've had one recurrence, and up to 60% risk for having multiple recurrences. So the Sunshine study that came out in 2019 was really an important addition to understanding pediatric treatments for C. difficile infection. It's not common that children get a randomized controlled trial to really use and to put forward an application to the FDA to even have a label to treat children. So this was a very important study that allowed fidaxomicin to be approved for the use of children even down to 6 months of age. They compared fidaxomicin to vancomycin twice daily versus 4 times daily. And the primary endpoint was to see if the patient had responded to the medicine 2 days after ending the antibiotic treatment, and then to see if there was any recurrence 30 days after ending the treatment. And overall, fidaxomicin performed a little bit better in terms of the short term, but definitely better in terms of the longer term outcome, their secondary endpoint. And both treatments had a similar rates of adverse events. And I think was also important to understand in children is, does this medicine get absorbed differently? Is the pharmacokinetics different in children? And so those things, I think, helped to also show that the safety of this medicine, of fidaxomicin, was still quite good and targeted. So I think from there, many of the people in my community that work with fidaxomicin and take care of these patients thought, that study was really transformative in getting us fidaxomicin available. But the question really came is, like, does it work as well in our medically complex children? Because as we pointed out, many of the children that get C. difficile infection actually have another underlying diagnosis, and does their C. difficile infection behave similarly or different than the children that don't have as many comorbidities? So in a collaboration that I put together with some of my colleagues at Boston Children's, Vanderbilt, CHLA, and Inova, we retrospectively looked at several years of experience using fidaxomicin to treat C. difficile infection in young children. Everyone had to establish that they had appropriate symptoms and positive testing. We excluded people who did not have the symptoms at baseline or who did not get a complete antibiotic course or didn't have data to follow. And we looked at the outcomes of cure and response. Cure meaning that the resolution of diarrhea was completed, that there were no other signs or symptoms continued at the endpoint, or response, that their symptoms improved, but they didn't completely resolve. And then we also looked at failures, no improvement or resolution of symptoms. And from those patients that either had a cure or response, we wanted to follow up in the day 14 to day 60 window to see, did any of those patients have a recurrence after the fact? So we assessed outcomes at T1, which was day 14, and T2, day 60. And what we found overall is that 50 of 95 patients included were cured by fidaxomicin by that day 14 time point. Overall, 83.2% were improved by that time point. The inflammatory bowel disease, having that as a co-diagnosis, made it less likely that you would be cured at the T1 day 14 time point, and having had a prior FMT, so insinuating that you had had multiply recurrent C. difficile infection, and then we're getting your first course of fidaxomicin after the fact, that also made it less likely that you would be cured. But I think the most intriguing finding was the patients that had the 60-day relapse. So of the 79 patients that had cure or response, about 17 of them had recurred. And the patients who had undergone a solid organ transplant had an odds ratio of almost 8. So 8 times as likely to potentially have a relapse. And that was really an unexpected subgroup to see such a high risk. And I think that goes a lot to understanding what those patients are being treated with and what their immunosuppression is and what their disease course is. And we need to know more about them. So we found that fidaxomicin was effective for CDI in children. Majority of our medically complex patients just demonstrated response, and about half of them were cured. This highest risk of recurrence at 60 days was among the solid organ transplants. And of course, there are challenges of doing retrospective research, and especially doing retrospective research that includes multiple institutions that can have different strategies for testing and different clinical outcomes recorded and determined recurrence. But we really felt like more research is necessary here to look at longer-term follow-up, understanding fidaxomicin susceptibility and how that has shifted from the beginning end of our study window to later on, and the cost-effectiveness of using fidaxomicin earlier. Because I think it's important for us to realize that fidaxomicin doesn't exist in pediatric guidelines right now. There has not been an update in many years. And so I think the question of how helping the pediatric community on how to use fidaxomicin still remains. So as an alternative to antibiotic therapy, the other major intervention for treating recurrent C. diff has always been fecal microbiota transplant. And so again, we in pediatrics often have to use retrospective data to really help us inform future studies and future use of interventions. So the largest review of pediatric fecal transplant was done by Mary Beth Nicholson and many other thought leaders in the pediatric GI space. And about a third of them had underlying IBD with their C. diff infection. Over 100 of them were immunocompromised, and about 20% had a feeding tube. But she and the group found that about 81% had a successful outcome after FMT. And amongst those who had had a recurrence, many of those had gotten a second FMT. So overall, the success rate of getting 1 or 2 FMTs was 86.6%. So it really showed that FMT for children was as effective as it has been reported in other larger studies with adults. And things that really predicted success for this was using fresh donor stool, was providing delivery by colonoscopy, having no feeding tube, and then having less episodes of C. diff prior to your FMT as opposed to having multiply recurrent C. difficile infection. I think what comes up with FMT, particularly in children, is what are the safety concerns. In general, what's been reported as the short-term self-limited adverse events are pretty similar to what's been reported in adults, many sort of GI symptoms. Amongst this pediatric FMT study that I just discussed, about 19 had adverse events and 10 were hospitalized for these events. And the IBD patients, we think about the risk of exacerbation of their disease post-FMT. And there has been studies that looked at FMT for recurrent C. difficile in IBD patients themselves. And there we also have seen some hospitalizations and surgeries, but most things related to their IBD disease exacerbations. The serious adverse events in adults have not been reported in children, but we think about these all the time and about the risks of them. They've also looked at the risk of FMT for patients who have immunodeficiency, and there have been some serious adverse events with those as well. But again, these are very sick children who have this risk with having C. diff infection multiply recurrent as well. So I think we're always weighing the pros and the cons, the risks and the benefits with the child and the family, which I think is a huge piece. One major area that requires more research are the long-term effects of FMT, particularly in children, because you have to remember that donor stool often and most frequently comes from an adult donor. And so I think the risk and the long-term effects of adult donor stool into a child, there's a lot of question marks there. And I think that's been the basis for our interest in establishing a pediatric stool bank in the future. And then, of course, our bigger concern right now is the limited access related to the end of the FDA enforcement discretion and what patients and providers are supposed to do with limited resources. And thinking about, minimizing the risks of recurrent CDI and preventing it, these are the therapies that are currently available. Bezlotoxumab was the only one available to children and is no longer available, of course. And Vowst and Raybiota have had some success, but overall are still indicated for adults over 18, so not been available for children. And so the recent establishment of the CHOP Center for Microbial Medicine is really hoping to be part of the story here of making children have a, I'm sitting in the dark, I apologize, my lights went off. We're really trying to help develop microbiome-based therapeutics and use big omic data that now exists in the world in many different settings and have it make it useful for clinical decision-making. We're hoping to enable clinical trials in live biotherapeutics to children and bring things like a pediatric stool donor bank to FMT for children with C. difficile infection and potentially for other indications in the future. We currently are participating in the Vedanta VU303 trial, which I know will be talked about later today. We are very excited about this trial because the recruiting age starts at age 12. And so I think it's just great to have an option for some available potentially for our younger patients. But I think there's still room, of course, for figuring out ways to introduce interventions for children younger. And as I said, our experience at CHOP is that our mean age is quite young, about 8 in the past few years, who have a positive C. diff test. And so we need medicines that are available to young children with less risks. So in conclusion, community-acquired C. difficile infection in children continues to rise. Children have limited treatment and recurrence prevention options, and additional clinical trials and novel therapeutics are really necessary and need to be thought of as pediatric-friendly options. I think I can't employ more of the ways that we try every day to make adult things work for kids, but it really is it's a challenge in this field. Thank you so much for your time.
Well, thank you so much, Dr. Conrad. That was, I could feel you starting to kind of race towards the end.
Trying to keep on the schedule,
Yes, and we do appreciate that because we have been falling behind most of the day. So we did have Caitlin asked, and I think this is something that is of interest to all of us. So we know that the decision to end enforcement discretion has definitely limited access for FMT for pediatrics. And so Caitlin was asking, where do you send your patients that need an FMT? Like, if their life is at risk, like what can be done for those kids?
Yeah, I mean, I think some of my colleagues have gone back to screening for the individual patients, donors themselves, and providing sort of donor-directed FMT when those really serious cases. We do at CHOP have an IND to do FMT, so we do still have it available, and I think that's part of the strength of us building a pediatric stool bank as well, is to be able to bring FMT and still have it available, at least at our institution. So, and I believe there are other pediatric institutions that are affiliated with adult hospitals, so have a little bit more access, or at least some buy-in on how to sort of make those make things available, whether it's a off-label use of a different product, or to bring FMT from an individual stool bank institutional. So I think it's about finding the right center, because it still is out there. It's just not available to everyone, and there's some people that's not an option to travel.
Yeah, and something that I've been frustrated by is the FDA's sort of definition of what commercial means. Mm-hmm. And so we do have centers, like you guys obviously have one. There's one at Mayo, there's one at Mass General, like we know a few others, but oftentimes if they even just want to send it outside of the center, then they're sort of running afoul of the FDA. And yet if the place is not equipped to take care of children, and Boston Children's is, like, yeah, they're literally down the block, like we should not. So anyway, we're mad. We're going to be, FDA will be hearing from us. They have been, but they're going to hear from us again.
Keep going.